So, ladies and gentlemen, friends, colleagues, attendees, welcome to the OrbusNeich Combo Work Plus webinar. And today's webinar is entitled "Protecting What Matters," and it's an important issue. And we have distinguished speakers as members today. I am Dr. Azhari Rosman. I'm a cardiologist from the National Heart Institute. It's an honor for me to chair this session. And our main key chairperson probably is Prof. Chikohan. He's from the University of Malaya, and he's also a senior consultant cardiologist at University of Malaya in Kuala Lumpur. Now, Prof. Chi will be our manager for the chat that you type, and he will answer some of the questions and raise some of the questions that you have actually typed at the end of each session if we have time. So each speaker will speak for about 10 minutes or so. And then if there's time, we'll answer 1 or 2 questions, and probably at the end of the day, we'll have some questions. So this session will last from 4 to 5 o'clock in the afternoon. We have 4 speakers: Dr. Liu Hongbang from Queen Elizabeth Hospital, also senior consultant cardiologist, from Azman from UMC. Really needs no introduction also. He's been with us and a distinguished speaker. And Dr. Bala from National Heart Institute, my friend. He's a senior consultant cardiologist. He will be presenting a case. And our distinguished guest honor from Singapore, my good friend, Prof. Tan Hui Chim. He's a distinguished speaker, very involved, involved in so many interventional talks, and is an excellent speaker. They will all share with us experiences on DAPT and flexibility and treatment in ACS patients with the newer combo stent. This combo stent has been available since 2016, but I think its use has now obtained the CE mark for short DAPT usage. You'll hear more of it in a short while, as well as the science behind it. So now, without further delay, let's welcome the first speaker for today, which is Dr. Liu Hongbang from Queen Elizabeth in Sabah. Dr. Liu, how are you?
Hi, hello, good afternoon.
Yeah, so you're here to present
Hi.
combo collaboration, yes, the collaboration and the real world registry for us. Once again, thank you very much. You have 10 minutes, and yeah, the screen is yours. Thank you, Liu.
Thank you very much. Thank you very much, Dato, for your kind introduction, and good to see everybody here. Okay, so my talk is on the combo collaboration, the real world registry. You can see my screen. Shall I start?
Yes, please do. Let's go ahead.
Great, thank you. So as we know, the combo stent has been around for some time now, and is a very unique technology. Those of us who are familiar with this, we know that this is in some ways a stent, a drug-eluting stent in its own class. The stent platform, has the abluminal layer, which actually control neointimal proliferation because it has sirolimus to prevent intimal hyperplasia. On the luminal side, we also have the endothelial progenitor cell monoclonal antibody, or the anti-CD34 antibody. And this is a unique technology to capture the circulating EPC to speed up, the healing of endothelium. So as we see here, this is what happened when we put the stent in, and we have the surface of the stent facing the lumen, and it captures all the circulating EPC. And as we know, EPC is a natural cell. It goes up as we have an acute vessel injury in acute coronary syndrome. They said the circulating endoprogenitor cells generally takes time to to coat a stent, but in the presence of the monoclonal antibody, this primitive layer of EPC will form on the surface of the stent within a week. And of course, as we know, as we do OCT in the combo stent, as seen by some of the studies, we can see there is actually early strut coverage at 2 months, and at 3 months, it already reaches 90%. And this is very reassuring because, as we know, if you have a layer of endothelium covering the metal, that will reduce the risk of thrombus. And this is shown as well in this study that look at the fibrin score, the intimal inflammation score, that the combo stent with the biodegradable polymer and the EPC does compare to the other technology like the contemporary drug stents or the old generations of stents like Cypher, has much lower fibrin scores, and inflammation score.
Okay.
So this is the latest study that look at the OCT of the combo compared to the Zions, and it shows that you have a healthy, endothelium, a healthy tissue coverage, and people have looked at this and measured, what constitute a healthy endothelium. At least 40 microns, from the strut, constitute a good healed vessel. Can you see that slide? This is a combo clinical trial program. You can see the many studies here, and we have had now over the many years of combo stents, 9,600 over subjects enrolled in various studies. Some of them are registries, and of course, also the randomized control trial. I'm just going to focus today to talk about the registry, the Remedy registry, which is one of the early registry that we have, which is actually in Europe for 1,000 patients. But then, of course, we have the more contemporary registry, the Mascot All-Comer registry, which also include Asia. And I believe here many of us are actually, site involved in this registry. And you see here, the context of this registry is to see in the real-world setting, high thrombotic risk patient who have complex lesions. And we want to assess how these stents fare in terms of durable safety and also in terms of DAPT flexibility. I'm showing now the Remedy registry. Just a quick recap. This is a registry involved 1,000 patients, and we look at the TLF at 12 months. Now, we also have the Mascot registry, as I said. This involved 2,614 patients. Now we combine these two registry and we do an analysis, and this is just published not too long ago in the JACC, looking at the 1-year clinical outcome of all comers treated with this dual therapy combo stent. So here it is. We combine the two registry. We have these patients that enrolled in the contemporary era, in the 2014, 2016, and then we look at the primary endpoint of target lesion failure at 1 year. And the target lesion failure here, we're looking at cardiac death, target vessel MI, and clinically indicated target lesion revascularization. So the combo collaboration is a fairly big number of patients, 3,614 patients. Who are these patients? And these, I believe you agree, are very much what we see. Half of these patients are acute coronary syndromes. Many are diabetic. In our Malaysia and Singapore, I'm sure we know, we have been handling almost a third up to 50% of diabetics in our practice. We also see this patient who has a history of MI, history of PCI. In terms of the lesion characteristics, majority, 57% of these lesions are type B2C lesions, so they are complex lesions. And this is what we find. This is the main finding. The primary endpoint at 1 year shows that it is very low for this group of patients who are considered high risk. A recap: 54% are ACS, 37% are diabetic, 57% are type B2C lesions. We're talking about at 1 year, the TLF rate of 3.9%. And when we look at the multivariate analysis, we also learned that the independent predictors of 1 year TLF are insulin-treated diabetes, no surprise, the chronic kidney disease patient, and again, complex lesions per se. When we look at the component, cardiac death, target vessel MI, clinical-driven TLR, all these events are generally very low. And of course, what is very reassuring is also the definite stent thrombosis rate, which is at 0.5%. Hello?
Yes, I can hear you. Yeah,
okay.
I can hear some interference somewhere.
Now, I'd just like to share a case here. So this is one of the patients. He came in on the 18th of December 2015 with a chest pain. And you agree, this is a high-risk patient. He's 63, he's a hypertensive, he's a patient with
I've lost your audio, Liu. Hello? Okay. Hello? Hello? We've lost your audio, Homang. You're on. You muted. I think you accidentally muted yourself.
Sorry about that.
Okay. All right.
Can you hear me now?
And you need to put on slideshow once again.
Yeah.
Yeah, I mean these technical glitches are a normal part of.
Where did you lose me? Did you lose me?
I lost you when you presented the case. When you
so you saw the 1 year clinical events.
Correct. I saw that one.
Okay, great. So I was just presenting about this gentleman who came in with acute chest pain, and he has acute left main syndrome.
All right.
This is the angiogram that shows the very tight acute, what's it, the left main stem distal disease, and you can see the slow flow. This patient, underwent PCI. We have a pre-dilatation followed by a stent, and he was given 3 months DAPT. Okay, it was a big stent. It was 4.0, and then we post-dilated with a 5.0. And this is a follow-up at 3 months. This is a routine follow-up. This is not a clinical-driven thing, so it is good. Okay, the result is still good. And of course, we had the opportunity. He agreed to this, to have a extension, to follow up again. So now we look at the 15-month surveillance. Again, we see the stent still looks good, and the patient's doing well. We've seen this patient about 6 months ago in the outpatient, and he's doing well. So not just at 1 year. Now, this is not the combo collaboration, but this is the remedy per se. So in the remedy, now we have 5 years. And again, we see this very sustained low stent thrombosis rate. And in fact, there was no stent thrombosis cases reported beyond the 3 years. So with that, I think now we have the opportunity for a shortened DAPT. We had that flexibility to use shortened DAPT, particularly, let's say, patients that we are concerned with bleeding. And these include patients, who are acute coronary syndrome, that we can actually shorten the duration to 3 months. The European guidelines, of course, generally recommend 12 months for the ACS, and of course, we can shorten it to 6 months for the patients who are, high bleeding risk. But I think combo gives us that assurance we can even shorten it to less. So take-home message: the combo collaboration presents the largest cohort evaluating 1 year clinical outcome for the combo stent. The low clinical event rate at 1 year after placement, despite a high risk population, ACS, diabetes, and type B2C lesions. This is a real-world clinical evidence of both efficacy and safety. And I believe the EPC capture technology gives this stent that extra edge of a rapid, early functional endothelium recovery. And of course, as we see, very sustained low stent thrombosis rate. So with that, thank you very much. Apology again with all the technical glitches. I'd love to have questions.
Yeah, it's part and parcel of it. Thank you very much, Omang, for a wonderful lecture. We are good for time. Is there a chat master? Do we have any questions on the chat box, please?
Yeah, so far none.
Okay.
But I actually have a question for Hombang. As in, I mean, you actually have shown us a very fantastic case of a left main stent with a combo stent. Do you think combo will actually have more advantages compared with the rest of the stent in the setting of left main, Hombang?
Well, I've shown you where you have the comparison to the Zion study that you have OCT, and that I think is very assuring. But of course, I think nowadays I always say the modern generations of stents are doing fairly well, at large, and it's very hard to claim superiority of any particular one stent against another. Overall, I think over the last 2 decades, we have seen improvement in performance of these drug stents. But I think what we want to look at in terms of now is a safety profile. So I think this is where we talk about we're handling more and more complex patient, complex lesion, elderly, bleeding, and not forgetting in the era of COVID-19, we have patients have difficulty sometimes returning for follow-up. And this discontinuation of DAPT will pose some challenge. And I believe with a stent like this, it does give us that, safety margin, that flexibility. So that's my opinion.
Totally agree. Yeah, totally agree. Right. So back to you, Dato'.
Thank you very much, Kohan, for that comment and question.
You're welcome.
Our next speaker is a distinguished individual, Prof. Azman, Dr. Prof. Azman. He will talk about REDUCE. He's from University of Malaya. REDUCE trial is a study about DAPT flexibility in ACS patients. Prof. Wan, you have the screen.
Yes, colleagues, ladies and gentlemen.
Your audio is muted, I think.
Okay. Thanks, Azhari, for your introduction. Can you see my slide or not?
Yes, I can hear you.
Yeah, the title of my talk is REDUCE, Evidence of 3-month DAPT Flexibility in ACS Patient, including SEMI. Dual antiplatelet therapy, aspirin plus a P2Y12 inhibitor, is the cornerstone treatment after PCI for ACS. Prolonged DAPT may prevent thrombotic complications. This benefit may be counterbalanced by the subsequent increase in major bleeding complication. Major bleeding on DAPT has an impact on mortality after an ACS that could be even greater than recurrent myocardial infarction. Among ACS patients, about 1/3 of patients belong to the high bleeding risk category. This is a $1 million question. With the newer generation DS, where the shorter duration DAPT is safe after PCI for ACS patients in the contemporary era. So this is tested in the REDUCE trial. REDUCE stands for the randomized evaluation of short-term dual antiplatelet therapy in patients with acute coronary syndrome treated with a combo dual therapy stent. This is the first study conducted in ACS-only patients treated with a new generation DS to test the hypothesis that treatment with DAPT for 3 months is non-inferior compared to standard 12 months DAPT with regard to combined safety and efficacy endpoint. The final result of this study was published in a coronary intervention clinical research. Malaysia contributed significantly to this study. We have 252 patients from Malaysia. Why combo stent? I do not want to go into detail as Dr. Liu Hongban has elucidated to you in much detail just now, but this novel technology may allow for shorter duration of DAPT after PCI in the setting of ACS. In the setting of ACS, there is upregulated of EPC in the circulation. These have an advantage. If you look here, the EPC level after SEMI here, the number of EPC level is much higher, and plateau at 24 hours and remain high at 7 days. This will promote rapid re-endothelialization and acceleration of vascular healing, and this will be advantageous in the highly thrombogenic ACS patient. It's very well established that early surface endothelialization is important to lower the clinical event rate. The REDUCE was a prospective, open-label, multi-center, investigator-initiated study that randomized 1,496 ACS patients after treatment with a combo stent to either 3 months or 12 months DAPT. The primary study endpoint was a composite of all-cause mortality, myocardial infarction, stent thrombosis, stroke, target vessel revascularization, and bleeding BARC major 2, 3, and 5 at 12 months. This is the study design. Okay, we have four patients withdraw from the randomization. So we have 1,496 patients randomized to 3-month DAPT and 12-month DAPT. You look here, of note, the 12-month follow-up is more than 98%, and the 24-month follow-up is more than 97%. So we are dealing with really very high-risk patients. About half the patient, 50% of the patient are SEMI, about 20% of the patient have diabetes, and about 11% or 12% of the patient have previous ACS. And if you look at the angiography and procedure characteristics here, about 1/3 of the patient have multivessel disease, about 1/4 of the patient have TIMI zero flow, and about 12% of the patient had thrombosuction. So you look at the clinical characteristic and angiographic and procedure characteristic, you are dealing with a very high thrombotic patient here. So this is a primary study endpoint at 1 year follow-up. On the y-axis, the cumulative survival free from primary endpoint. And you look at the x-axis here, yellow here is a 3-month and blue here the 12-month. So there is non-inferiority is met. So there is no difference between 3-month DAPT and 12-month DAPT. So this is the 2-year follow-up here. On the y-axis, the composite of all-cause death, myocardial infarction, stroke, TVR, or bleeding. And you look at the blue here 3-month, the red 3-month, and the blue 12-month, you can see that the line meet each other. But after 570 days here, the 3-month DAPT seems to be better. The TVR at 2-year follow-up, also there's no significant difference. If you look at the safety endpoint, you look at mortality, the p-value is 0.2. You look at cardiac mortality, the p-value is 0.2 as well. The myocardial infarction, the p-value is 0.4. The stent thrombosis, the p-value is 0.1. So there's no significant difference between 3-month versus 12-month DAPT. And this study, you look at very low stent thrombosis at 2 years. I'm going to present you the reduced sub-analysis, which is just published this year in the Atherosclerosis Journal, looking at the age, impact of age. This is comparing patients more than 75 years and less than 75 years. So if you look at this box here, more than 75 years, all right, the 3-month DAPT and 12-month DAPT, there's no significant difference here, the p-value, and the less 75 years, the p-value also show no difference here. So look at the 75 years, though the numbers are small, but you can see that the 3-month DAPT versus 12-month DAPT, there's no difference in terms of primary endpoint and all the other individual endpoints here. So the conclusion of the study, among ACS patients treated with combo stent, 3 months is non-inferior to 12-month DAPT at 2-year follow-up. The trial demonstrated a short DAPT strategy can be considered, if necessary, even in ACS patients, especially in high PD risk patients or in the setting of primary PCI, as it's difficult to fully ascertain whether the patient will be taking long-term DAPT. A DS with EPC capture technology may be safe in early DAPT interruption or short DAPT duration if clinically mandated. And this has been shown by Liu Haoban, the CE approval, 3-month DAPT for ACS patients and 1-month DAPT for stable patients. The sub-analysis study on advanced age more than 75 years old reinforces the opportunity of a shorter DAPT duration even among high-risk subset of elderly ACS patients. In addition to its prognostic impact and the cost related to bleeding complication, a short-term DAPT strategy, especially in the era of new ADP antagonists, certainly provide advantages in terms of cost reduction. So, ladies and gentlemen, thank you for your attention.
Thank you very much, Juan. That was a wonderfully succinct and very clear lecture to the case forward for the short-term use of a DAPT. Kohan, any questions on your side?
Yeah, always from me, Prof. I think this reduce is always it's actually a fantastic study. I think it's actually very focused, looking at acute coronary syndrome group of patient, which is actually the bread and butter of our service. So my question is, with the findings from the reduced study that Prof. Wan have shown, should we change our ways of do antiplatelet strategy, or we only change if you're actually facing with a high-risk patient, Prof?
Okay, a great question here. If you look at this study, was conducted 2014 and 2016. It's about 6 years now. And lately, you can see that more study be presented during the even the EuroPCR or even in the ACC, that shorter duration of DAPT. And even people are looking at now, even 1 month DAPT now, that is seems to be safe. All right, particularly with the new potent anti with ticagrelor in the second ACS. Even though the guidelines have not changed, if guidelines say that if the risk of bleeding, you always have to balance between the ischemic risk and the bleeding risk. All right. If the bleeding risk is even if the bleeding risk is high and the ischemic risk is low, then you can even use a shorter duration DAPT, even 6 months or even 3 months. Our patient, we need to go for surgery, and after 1 month, I need to stop the DAPT, and patient went fine. So I think we have used our clinical judgment. It's always a clinical judgment. These are all guidelines. Okay, if the in general, if the bleeding risk outweigh the ischemic risk, then you can shorter your. It's quite safe from all the studies, and even there are many other studies and meta-analysis which have been published lately, which show that even 3-month DAPT or even 1-month DAPT is safe if clinically mandated that you need to stop the DAPT. So now you are a bit more confident now to stop the DAPT at a shorter period if needed.
So if I can sort of extrapolate from what you have said, Prof, that means when we're actually dealing with patients with acute coronary syndrome, when we're actually deciding on the stent, we actually should choose the stent either with clinical data to prove or regulatory approval to prove that we should put in a stent that actually have approval for actually a shorter DAPT, just in case if the patient actually bleed. Is that what we can conclude from a reduced study and others?
Yes, that's what my practice. I think we cannot generalize. But I think if there's a study to show that that for whatever reason this stent is able to reduce DAPT, I would select that particular stent rather than generalize to all new generation stent.
Thank you, Prof. Yeah, back to you, Dato.
Thanks, G. Yeah. I think the CE mark gives you some assurance, and it just gives you the flexibility. You might not change your practice so much, but it gives you the flexibility in some of these individual patients if you need to. Thanks, Juan, for the wonderful lecture. So our next speaker is, of course, no stranger to IJN. He's Dr. Bala. Dr. Bala is a good friend and colleague of mine. I can't think of anybody more passionate about interventional cardiology than Dr. Bala. And he's had a lot of experience in interventional cardiology, and he's here to actually discuss some case about the use of DAPT flexibility from his vast experience. Dr. Bala, you've got that.
Yes, I'm trying to get through this. Good afternoon, everybody. After listening to these factual details, I will go to our personal experience in IJN of 2 cases which we have encountered high bleeding risk patients for DAPT therapy. I'm trying to get the slides sorted out. Okay. DAPT flexibility in clinical practice. That's our topic for today. In our daily practice, we have an unknown patient comorbidities and background are the challenges faced with ACS patients during PCI. High bleeding risk patients such as female, sex, CKD, diabetes mellitus, and advanced age are becoming common in daily clinical practice. So the long duration of DAPT post-PTCA poses a high risk of bleeding in these high bleeding risk patients. It is therefore challenging to balance the risk between thrombotic and ischemic in high bleeding risk ACS patients. So we have to weigh the pros and cons of the choice of stents, as Prof. Wan was just telling. Patients who have high bleeding risks and who have comorbidities. DAPT flexibility is thus important to reduce the bleeding complications and yet not compromising the thrombotic complications. So a stent with DAPT flexibility therefore allows to shorten the DAPT treatment regime confidentially and safely when necessary. So we move on to our case studies. This is a patient we had about 2 years ago. She is a 63-year-old lady, hypertensive, diabetes. She's got end-stage renal failure on hemodialysis. She presented to us with complaints of hypotensive episodes during hemodialysis. She tolerates about 1 to 2 hours of dialysis before she becomes hypotensive and the dialysis has to stop. Baseline findings, you can see that the echo, there's regional wall motion abnormalities. Ejection fraction is about 48%. And in her ECG, she's got Q waves in lead 2, lead 3 AVF, and no significant SCT changes. She was treated for non-STEMI. As baseline, we did an angiogram for her. You can see she's got a calcified proximal RCA and a calcified proximal LED lesion. So now the dilemma is, She has got two vessels which had highly stenotic lesions which are calcified. So we had a discussion with her family members for a stage procedure involving the opening of the right coronary artery and later the left anterior descending. She's a high bleeding risk patient with renal disease. She's got anemia. And so a strategy was planned for her for short DAPT treatment with a combo plus dual treatment therapy. This is a repetition of Prof. 1's slides, which shows in the reduced study the use of combo stents, stent thrombosis, cardiac events less than 2% over 1 year, and the CE approved combo dual therapy stent with a DAPT flexibility, wherein the use of patients with stable, patients with 1 month dual antiplatelet, patients with ACS 3 months dual antiplatelet therapy. This is CE approved. So we proceeded with doing her angiogram. The right coronary artery, as you can see, that's just a repetition, is a very calcified proximal vessel. And we use a guide catheter AL1, a guide wire, run-through floppy, which we exchange with the Fielder XT, and exchange Viper wire with the micro catheter. This is the OS procedure. It was OCT guided, low speed at 80K 3 runs, and high speed 120,000 at 1 run. Okay, after the OS procedure, we pre-dilated the lesion with Sapphire NC30 at 16 atmospheres, and we deployed a stent. You can see the typical combo stent, which opens from the sides and then moves to the center. 3.5 × 23 and post-dilated with the Sapphire MC 3.5 × 15. The results were quite good. Good flow, good TB3 flow. It was achieved for the right coronary artery. We stopped the procedure there because she's an end-stage renal failure on dialysis. We don't want to burden her kidneys with too much contrast. This is a discharge medication at that point in time. 3 months, clopidogrel 75, aspirin 100, followed by a single antiplatelet. These are her other medications: bisoprolol, amlodipine, lipantil, atorvastatin, insulin, and controlol. So now we stage a procedure 2 weeks later. She is not, she's pain-free, she's quite comfortable. So this is what we did for the left side. You can see this side, very calcified lesion here, see? The spider view, and in the cranial view, you can see a very calcified proximal segment. And we proceeded with the orbital atherectomy involving the proximal LAD lesion, low speed at 80,000, 5 runs, and we used 1 run of the high speed at 120,000. Post-OAS, you can see a lot of cracks and fissures. This was confirmed by the OCT findings. And then we post-dilated, we pre-dilated the lesion with the Sapphire NC 2515. A combo stent was placed. 27523 and post-dilated with the Sapphire NC 30 × 10. Right, this is the findings pre-PCI and post. Can't get that moving picture. All right, that's what you see post. Right, there was a good flow there, and this is her medication as you had seen earlier. This we kept her dual antiplatelet for 3 months and subsequently single antiplatelet 1 month. We chose clopidogrel because she had some gastric problems. She has been following up with us for the last 1 year, and she's quite well actually, tolerating hemodialysis, 4 hours of hemodialysis. Our interesting second patient will be a 61-year-old male. We just saw a few months ago, seen at the emergency department at 10:30 presented with epigastric discomfort for the last 4 days, and he was treated by GP as gastritis. However, the pain persisted, and he came to us. His comorbids are his diabetic, chronic kidney disease, hypertensive. He's got a dual chamber pacemaker for complete heart block, which was implanted in 2016. In 2016, he had a PCI to the circ also. ECD findings were just paced rhythm. TROP-T was 4,114, hemodynamically stable. We were surprised when we saw the echo finding, which showed EF of 38% with a left ventricular apical thrombus. Right, that's what we saw. So now we are planning for angiogram for a patient who have got ACS with myocardial infarct, low EF, and with an LV apical thrombus. So now the consideration of an anticoagulant. And the other comorbid is a chronic kidney disease. This is his angiogram pre-procedure. You can see the proximal LAD up to diagonal 1, and another lesion in the distal RCA, distal segment RCA extending on to the PL branch. So we did both his findings in the same sitting. We did a LAD to the PCI, Sapphire, combo plus 30 times 33 at 10 atmospheres, and post-dilated with a 35 times 15. Right, that was a stent, and quite good flow we got down the vessel, well deployed stent up to the origin of the LED. Okay, so we did the right coronary in the same sitting, pre-dilated with Sapphire, with the stent combo plus 3033, and post-dilated with the NC balloon. And the final angiograms. So this is a high bleeding risk patient, which we have to add on warfarin for his apical thrombus. So he went home with the clopidogrel, cardiopterin, and subsequently cardiopterin with warfarin. But we will do a transthoracic echocardiogram at 1 month, 3 months, and 6 months to visualize the LV thrombus. So there you have. DAPT flexibility is needed for ACS patients with unknown risk factors. In our setting, ACS patients with high bleeding risk and diabetes are common, as in Asian populations. The results in reduced RCT 100% ACS demonstrated that 3 months is non-inferior to 12 months, including STEMI patients. Combo plus with CE mark of 3-month flexibility could potentially benefit ACS patients with high bleeding risk when clinically indicated. Thank you.
Thank you very much, Bala. That was the second case particularly tricky. Thank you once again for that nice presentation.
Yeah, thank you.
Thanks. So, I mean, what is the shortest duration you would be comfortable about putting these patients on antithrombotics? You see, the second case is of particular interest because it also includes patients who are already on anticoagulation for atrial fibrillation, for example. It just so happens that you're integrating for the thrombus this time around, but it also applies for AF patients. Now,
I think these patients are ACS patients, so you are quite comfortable with 3 months at least.
Okay.
Atrial fibrillation, stable patients, 1 month with NOAC is okay.
Okay. Any questions on your side, Kohan?
Yeah, I think there's a question from Kale88. Based on the combo safety profile, will you actually recommend combo for patients who actually require urgent surgery? So I think this is a good question for all the speakers today. Yeah. For urgent surgery, will you recommend combo?
Well, who takes that?
So
Maybe
I think
we ask Dr. Balo. Yeah. Sorry. Go ahead.
Go ahead.
Go ahead, Dr. Bala.
So for me, I think it's when is the surgery planned for, and if it is For 1 month, I wouldn't hesitate giving for 1 month dual antiplatelets.
Okay. Bang, what do you think?
Yeah, well, I think, again, we got to look at the context of these patients' surgery and also the reason of their PCI. If the patient who have had a recent acute coronary syndrome, I often say, delay a surgery for a month. Generally we know the risk of perioperative cardiac event will be lower after a month. So that's the first point. But if it's a non-ACS patient and the patient, had an elective PCI, and this patient is scheduled for surgery, then I agree with Dr. Bala. If the patient, what I call it, can wait, let's say it's a cancer, you can afford to wait. I think again, about a month is actually a fairly safe time frame. I have had a few patients where, the surgeons felt, it's a bleeding lesion. And it's a judgment call to whether to go in 2 weeks' time or to wait beyond a month. And we decided to wait for a month, but the patient came with a bleeding. He's a PR bleed, and the patient had to go for a more urgent surgery. And at that point, the patient already 2 weeks plus a few days after the PCI, and he had a combo stent. And that patient turned out okay. We didn't have a stent thrombosis. Both the antiplatelet was actually stopped during that surgery. But of course, I always remind people, you're going to find a skillful surgeon. Make sure you have a short operative time, reduce the bleeding, make sure you come out okay, and then as soon as you can, restart the patient on an antithrombotic and bridge that in time back to an antiplatelet to complete it for 3 months. So that's how I handle that case.
Yeah, so for that, I think there's a good question from Dr. T. I think I will direct this to Prof. Wan. For those who are actually allergic to aspirin, who actually had an anaphylactic shock as a result of the aspirin, can we actually start ticagrelor alone post PDCA, Prof. Wan?
Thanks, Steve, for that great question. I think if for whatever reason patient cannot take DAPT, cannot take aspirin, I'm quite happy to keep patient on ticagrelor. But if there's a patient is a high risk patient, for example, this patient got a complex bifurcation stenting, for example, or patient with a high thrombotic risk, this merely a gut feeling lah. Maybe there's no data for that. I will add on oral anticoagulant, for example, apixaban or rivaroxaban, 2.5 milligram BD for about 1 month or 3 months, depending on the how complex the stenting is. Then I will continue on ticagrelor alone, because it's a study to show that in the setting, even the setting of SEMI, patient be randomized into DAPT for 3 months, and after that on ticagrelor alone for 12 months, and then the other continue on the stent therapy. And it showed that patients on single antiplatelet therapy do better because they have less risk of bleeding.
Yeah, I think the game is always about balancing the bleeding and the thrombotic risk. I think this unfortunately has to be individualized. But I would like to congratulate from Dr. Bala. I think the 2 cases that you have showcased is definitely a fantastic cases. It actually reflect a lot of thought behind all the intervention you are involved. At my side, actually, there's no further questions, so I back to Tato.
Thanks, Kawan. That's a very intriguing case. I think there's a lot more points that we need to discuss. But in the interest of time, it brings us now to introduce our next distinguished speaker, who's from Singapore. This gentleman needs really no introduction. He has been involved in so many CMA activities, live cases, and so on. And he's really a wonderful speaker, distinguished speaker, and excellent interventional cardiologist. So this is Prof. Tan Hui Chim. He is now at National University Heart Centre in Singapore. He's got some interesting data to share with us about studies that he's done. And his title today is called How Can Combo Benefit ACS Patients? Hui Chim, the screen is yours. Thank you.
Thank you very much. Let me just bring on my talk. I hope you can see my slides, but that was a very nice introduction, Azhari. Thanks a lot. So the topic here is how can combo benefit ACS patients? And so today we are talking about a combo dual therapy stent. But even when we are talking about EPC capture stent technology as a monotherapy by itself, it is something that actually NUH has been working on since 17 years ago in 2004. I remember a long time ago when we were first using it, that predecessor of combo stent, which is, let's see, let me just get this thing correct first.
The pure EPC coated stents at that time.
Correct. So it was a Janus stent, and so this was the very first EPC capture antibody stent that was implanted in NUH in the very first interventional cardiology meeting that was organized in NUH by NUH as well. That was 2004, where we implanted a Janus EPC capture stent into the patients with RCA infarct, and 8 months later we did an intravascular ultrasound. You can see that even at that time, without the drug coating, the neointimal hyperplasia was minimal and healing was fairly good as well. So that set off our numerous studies on EPC capture stent in our center, particularly in ACS. So what was the rationale for us using EPC capture stent in our ACS setting? First of all, we know that when you're operating in an ACS patients, you are doing it in a highly thrombotic milieu. There is a risk of delayed endothelial healing with drug-eluting stents from the earlier study by Vermani. And yet we also know that the rapid restorations of functional endothelium minimize the risk of stent thrombosis in the early period of patients presenting with ACS. And then it was alluded to earlier on by the Prof. Azman. We know that endothelial progenitor cells are mobilized in huge numbers from bone marrow during STEMI and peak at day 7. So if we can implant the stent with the capability to capture the circulating endothelial progenitor cells, we harness this increased level of EPC and obviously going to promote stem cells adhesion and improve endothelial healing. And we know that also in primary PCI, it is particularly difficult to ascertain the patient's suitability for prolonged DAPT. Oftentimes, we don't know about the bleeding risk profile of the patients. We don't know if he's going to go for surgery soon enough, or perhaps also what will be his compliance with drug therapy is like after the procedure. So if you implant a stent that will promote early healing, harnessing some of this endothelial capturing technology, perhaps we can look at shorter DAPT for these patients. So our earlier experience more than 10 years ago with Janus endothelial progenitor cell implantations in patients with STEMI, and we follow them up for intermediate up to 1 year and so forth. At that time, we were actually using DAPT for just 1 month, even without any of the data supporting it. So this is a 3-year follow-up of our patients implanted with Janus stents up to 3 years. And even with 1 month of dual antiplatelet therapy, which we give to all the patients of 384 of them who received 465 Janus stents, if you look at the 3-year stent thrombosis rate, it was only 1.3%. So that we were not seeing any increased incidence of early stent thrombosis, but that was earlier on. But now we have, of course, moved on to a combo dual therapy stent, which not only have this endothelial capture technology capability, but this is also in combination with the anti-proliferative drug release to inhibit restenosis in patients implanted with this stents. So there have been a number of combo clinical data in patients with acute coronary syndrome. We heard about the combo collaborations. We heard about reduce. I'm just going to focus on the NUHCS AMI registry here. Actually, we started out publishing combo dual therapy in patients with STEMI again in 2017, looking at the first 117 patients, and then we got it published in Asia Intervention. But I don't want to share with you this particular data here, but we actually expanded the registry by doubling the number to 260 over patients in our next study, which was published in Cardiovascular Revascularization Medicine journal. And then we actually follow them up for a longer period of time, even beyond 2 years, just to see how these patients do respond with combo dual therapy stents implanted during a STEMI episode. So this was a registry that was prospective. It was a all-comers So it was unrestricted STEMI. Anybody who come in STEMI undergoing primary PCI will receive this combo. This was a period between 2013 to 2016, so a span of 37 months. And we were looking at the primary endpoint of target lesion failure, which include cardiac death, target vessel myocardial infarction, and clinically driven target lesion revascularization. And we decided to study several time points for TLF during the hospital itself, 1 month, 1 year, and beyond the 1 year. So the median follow-up was 744 days, and so that's equivalent to about nearly 2 years of follow-up for majority of these patients. So let's look at this combo AMI registry patients of 260 and looking at their baseline demographics. And again, we are looking at diabetic of 31%. Now, many of these patients has got a previous history of myocardial infarction, previous PCI, and so forth. And we are also looking at a cardiogenic shock group of up to 10.9% of patients coming in with AMI. So this is a real life populations that you're looking at. This is compared also anterior STEMI accounts for 44.6%. Now, if you look at some of the earlier trials looking at the use of DES in patients with STEMI, such as examination trial or comfortable AMI, evaluating all the other second generation DES, you find that there are very few cardiogenic shock trial patients that they were enrolled. So we are looking at the real world sort of a group of patients who are particularly at high risk. And just to illustrate how high risk these patients are, IBP was implanted in 7.7% of patients, and the average stent length that was implanted was 21.8, again, compared to about 15 millimeter for the 2 trials that I've just mentioned to you. So clearly a more complex sort of lesions that we are looking at. Now, if you look at the baseline here, which is the patients coming in before the procedure, TIMI 0 and 1 accounted for clearly more than 80% of the patients. In comfortable AMI, it was only about 70. In examination, it was only 50% of patients were coming with 0 and 1. So again, this is a very high-risk group of patients coming in with a real STEMI here. And this is the primary endpoint of target lesion failure here. 55% of patients have multivascular disease. So we are looking at patients with very complex lesion. During in-hospital, TLF was 3.5%. 1 month was 3.8%, 1 year was 6.5%, and beyond at the medium to follow-up of 23 months, it was 8.8%. Remember, in the examination trial, which was looking at everolimus eluding stent, at 1 year, it was already 11.1% with the stent used in patients with STEMI. When we look at multivariate analysis, cardiogenic shock was the only predictor of a target lesion failure in our patients. Now, if we drill down to the individual clinical endpoints here, specifically looking now at cardiac death at 1 year is 3.8%, longer term 4.2%. When we look at definite or probable stent thrombosis, now we see an accrual of a stent thrombosis. Majority of it were what we term early stent thrombosis within the first 1 month. Late stent thrombosis occur in one additional patient, and a very late stent thrombosis occur in another patient. But if you just focus on target lesion revascularizations as well, look at the incidence of patients coming back for a repeat interventional procedure is really low at 2.3%. And this is really comparable with, again, the examination trial of 2.1% with the use of everolimus eluding stent. Now, if I have to drill down to the 6 cases of definite and probable stent thrombosis, just looking at some of the early cases of acute stent thrombosis occurring within the first 2 hours or so, the first patient vomited all his antiplatelet, so maybe he didn't have much of antiplatelet inhibition on board. One of the patients also had heart failure, so we're not sure. Again, when we do IVUS, there was nothing wrong with the stent implantation when he presented with stent thrombosis. So perhaps it was because of, again, the failure of platelet inhibitions or clopidogrel non-responsiveness and so forth. We have one late stent thrombosis at 6 months. This was a patient who stopped taking his dual antiplatelet therapy and has focal in-stent stenosis with superimposed thrombus. We have one very late stent thrombosis guy. He had a severe in-stent stenosis, but he was still smoking when he presented with stent thrombosis. The other two probable stent thrombosis was sudden death, of which we couldn't prove anything, but I suppose we will have to classify them as probable stent thrombosis. So overall, the rate of incidence of stent thrombotic events is exceedingly low with the use of combo stent. So if we remind ourselves again, 2017 ESC guidelines on DAPT, if you have high bleeding risk, you might consider 6 months of a dual antiplatelet therapy, and this is a class 2A recommendations. But now come to 2020 guidelines, and if you look at the patients who are extremely high risk, now we can look at either 3 months with dual antiplatelet therapy or very high risk of bleeding in patients with ACS, even 1 month of dual antiplatelet therapy. So I suppose, with our earlier experience with the use of Janus, and now with all this increasing evidence from a combo, particularly with regard to its mechanistic findings of early healing and so forth, they give us the additional confidence that if we can shorten our DAPT for patients who requires a very short DAPT, should the need be required. So let me just finish my last slide. Suddenly it went off. So I just want to conclude the presentations by saying that the NUHS AMI registry clearly demonstrated the safety and efficacy of the combo dual therapy stent in all common STEMI patients undergoing primary PCI. So up to now, when you look at all the multiple trials, there are 3,600 patients that have shown that the stent implantation is safe with no clinical events. 3 months DAPT is now approved by CE Mark, and I suppose that it is a safe choice now to use combo stent in ACS patients with a possible room to shorten DAPT if needed. Thank you very much.
Thank you very much, Richard. That was a wonderful, that's illuminating talk, and then singularly impressive data that you've shown us. So I think it's quite reassuring, as you've said, to use this stent in patients in whom you need a short-term DAPT, and that's increasingly the case nowadays. I invite any questions, Kohan. I must bid my farewell for now because I have another session starting at 5. So once again, thank you everyone for that wonderful session. Kohan, over to you, please.
All right, thanks, Dato'.
Thanks.
So I think the question that we actually in chat room is that, all of you guys in the panelists actually have shown fantastic data, whether it's actually from a registry or actually it's from the clinical trial, actually the fantastic result with the combo stent. So the question that we actually have in chat room, is there any lesion that you will particularly use combo stent? And if I can actually extend the question a little bit more, is there any lesion that you will not use combo stent? So maybe I'll pose this question to Bala first. Is there any lesion that you will definitely combo, and is there any lesion that you will not use combo, Bala?
I think I have more reasons to use combo rather than not to use. High bleeding risk patients, I am really convinced that 1 month and 3 months dual antiplatelet therapy is beneficial. I can't think of any contraindications as such,
Mm-hmm. Mm-hmm.
I don't know.
How about maybe I will ask Dr. Tan. Are you concerned about the side branch access?
Not so much about side branch access, but I tell you what are the patients that I'll use combo stent for. I think in ACS patients where you have a real concern with regard to the duration of the DAPT, and that I think will be a perfect situation. Or you have a patient whom you plan to do a non-cardiac surgery soon enough after your PCI. And I do know that Antonio Colombo have actually shortened his DAPT to 10 days for patients who need to go for surgery with the implantation of combo stent, just because of this EPC capture antibody technology. Now, as far as there are no strong contraindications with regard to the use, but certainly because this stent was never designed for small vessel stents, I will be hesitant to use it in the small vessel lesions, particularly those with side branches. They are small, about 2 millimeter or so forth. So I think for such small lesions, perhaps it's not so good to use currently a combo-based stent.
Yeah. All right. Thanks. Hong Bang, is there any cases that you will do or will not do using a combo stent? Hong Bang?
Sorry, I was on mute. Sorry. Yeah, I think the registry show in the all-comer registry, as we say, you can actually use these stents in a very wide range of clinical scenario, as what Prof. Tan has shown in ACS. The registry have shown that half of these patients have ACS, and likewise in the elective patients, if you have, as we said, the concern of high bleeding risk, and you like to shorten a DAPT, you foresee the patient, they need the surgery, these are good patients to use. Lesion per se, there's no specific. It is in comparison, as you say, you don't have the small size, like what Prof. Tan said, the very small vessels I probably won't use. Other than that, there's no specific lesion criteria that you wouldn't use.
All right, so I'm going to reserve the most difficult question to my boss, Prof. Azman. So with all the data that you show me with reduced and with all the clinical registry that Hong Bang have actually shown us, I mean, I will have to say it's actually an impressive result. So I'm going to ask this difficult question to you, my boss. Should we actually just use combo in all ACS patient, Prof?
I think we have to be good friend to everybody lah.
Yes,
yeah.
Prof.
You can have one wife, but you can have many boyfriend and girlfriend. Okay.
Yeah, but I think the EPC capture mechanism that as Hong Bang have shown us in the first lecture, I mean, it's definitely very intriguing, and I think that is definitely very, very useful. And as all of you actually have shown in the registry data and in the randomized data, like Profile have shown in reduced trial, I think definitely I would say it's a promising data, and I think combo definitely have a place in the management of acute coronary syndrome, especially in the patient who is actually going for urgent surgery, like what Prof. Tan has mentioned. For those who are actually high bleeding risk and maybe even in extra complicated cases that Bala actually have shown. I think this actually have definitely very intriguing mechanism as far as EPC capture mechanism is concerned. I think healing is definitely what all intervention cardiologists are looking for, and the data definitely so far has been supporting it even in high risk patients, especially in acute coronary syndrome, and as all of you actually have shown in your own research in all the registry. So I think it's a fantastic data, and I think all of you actually have shown us all the data actually support the combo stent, especially with the EPC capture mechanism. So I think there's no further question, and I would like to thank on behalf of Dr. Azhari for all the panelists for sharing us with great cases and great understanding and great basic science behind the combo stent, especially the EPC capture has been. So I would like to, on behalf of OrbusNeich, I would like to thank all of you, especially the audience who actually have joined us on a Thursday afternoon from 4 o'clock. So thank you very much, and I would like to draw a close to today's session. I think all of us have learned a lot. So the last word from me is that thank you for coming, and please keep safe for all of you. All right, thank you very much, and have a good Thursday evening. Thank you very much.